protocol for endometrial preparation in frozen embryo transfer cycles. And this is really important nowadays because we are assisting to an increase in the number of frozen embryo transfer cycles. And we, as clinicians, have to decide which type of cycle we are going to use in our patients. We usually choose between the natural cycle and the artificial cycle. And we still question ourselves which is the best protocol, the natural or artificial. And in order to answer this question, I'm going to divide the lecture into three parts because we have to take into consideration three important variables or factors. One is the efficacy. Are there differences in efficacy between both cycles? The second one is the cost. And finally, last but not least, the safety of the patient and the baby. Let's start talking about efficacy. During many years, a lot of studies have been published so far comparing the results in natural versus artificial cycles. But the problem is that all of them were retrospective or descriptive studies. And this is why when the meta-analyses were launched, the results were not of good quality. Both quality because the results were based on retrospective studies and there was a high heterogeneity in the population included. So the first two meta-analyses concluded that there were no differences, and the last meta-analysis found that there was a superiority in the natural cycle over the artificial cycle. But we have to focus on randomized control trials to try to answer this question. Until now, there have been 2 randomized control trials published so far designed to compare the clinical outcome between natural and artificial cycles. The first study was the Antarctica trial, which included 959 patients and compared the pregnancy outcome in modified natural cycles versus artificial cycles. And as you can see in the table, no differences were observed between both cycles. The second randomized control trial has been a larger study including 28 patients and was published in Lancet last year and included 3 groups. One was the pure natural cycle, the second one was the modified natural cycle, and the third one was the artificial cycle. And as you can see, no differences were observed among these 3 types of cycles. So if we base our opinion on these 2 randomized control trials, the answer is that there are no differences in pregnancy outcome between the 2 endometrial preparation protocols. In any case, I wanted to share with you the results of this study that has been conducted by our group. This is a randomized control trial designed not to compare pregnancy outcome. It was designed to compare the risk of preeclampsia between the modified natural cycle and the artificial cycle. But as secondary outcomes, we analyzed the pregnancy outcome, and you can see that per treatment group, we observed that the live birth rate was 10% higher in the modified natural cycle than in the artificial cycle. Moreover, I want to share with you our internal data of equivalencia because we annually review our internal results of the previous year. So this year, we analyzed our results of the PGTA cycles of 2024, and we compare the results of the transfer of these euploid embryos between the modified natural and artificial cycles. And we were impressed when we saw these results because we observed that the ongoing pregnancy rate was significantly higher, almost 20% higher in these modified natural cycles. Obviously, we have to take these results with caution because this is a retrospective analysis. But as you can see, the ratio is 2.4 after adjusting for age, BMI, and embryo quality. So, although the two randomized trials designed to see if there are differences in clinical outcomes says that there are no differences, recent analysis show that perhaps there is a tendency to better results in natural cycles. And if we are talking about pregnancy outcome, we should focus also on luteal phase, because obviously the luteal phase is completely different in these different types of cycles, mainly because in the artificial cycle, there is no corpus luteum producing endogenous progesterone. And this has a lot of implications. In fact, during the last years, we have demonstrated that the low serum progesterone levels, which were not measured many years ago, are related to poorer pregnancy outcome. So since then, we are measuring serum progesterone levels in artificial cycles, because the most important study is this one, is the one we published in 2021. We included more than 1,000 patients, and we observed that those patients having low serum progesterone levels the day of embryo transfer had 18% lower ongoing pregnancy rate. And these results were obviously statistically significant, but clinically very relevant. After doing this study, we started adding an injection of subcutaneous progesterone to those patients with low progesterone levels the day of embryo transfer to see if we could rescue the cycle, if we could normalize the results. And fortunately, it worked. So if you start with the rescue treatment since the day of embryo transfer, the results are completely comparable to those of the patients with normal progesterone. So the main message is that in artificial cycles, we have to measure serum progesterone levels in order to know if the patient is absorbing adequately progesterone, and if not, we can rescue the luteal phase. And what happens in the pure natural cycle? Well, in this case, no external progesterone is given, and this important paper showed that in those patients having a luteal phase deficiency, defined as having serum progesterone levels below 10 nanograms per ml the day before the embryo transfer, had significantly poorer pregnancy outcome. And the most important message of this paper, I would say, that is that 1 out of 3 infertile patients show inadequate levels of progesterone in a pure natural cycle. And this has been confirmed by other groups who have analyzed the same, the prevalence of luteal phase insufficiency in infertile patients, and usually it's 1 out of 3. So in this case, if you are using a pure natural cycle, perhaps it could be convenient to measure serum progesterone levels to decide if you have to add exogenous progesterone, because it has been demonstrated that this normalizes also the results. We acknowledge the difficulty of measuring progesterone in natural cycles because of the fluctuations, but if you detect a low serum progesterone level, you should start adding progesterone. Why? Because let me show you the results of our study, of a prospective study in modified natural cycles, in which we give systematically luteal phase support, and also we do the trigger with ACG. We measured serum progesterone levels the day of embryo transfer in a blinded manner, and then we analyzed the results. And we no longer see the graph that was showed before in artificial cycles. There are no poorer results in the lowest percentile. Why? Because the levels of progesterone in this case are very high in the first percentile or quartile. In fact, the mean serum progesterone levels in natural cycles in which we add exogenous progesterone is 26 nanograms per ml. It's double than the one observed in pure natural cycles. And this explains why less than 1% of the patients show inadequate levels of progesterone. So in this scenario of natural cycle in which we add exogenous progesterone, perhaps it is not needed to measure serum progesterone levels because the luteal phase is adequately covered. And this explains why this randomized control trial found better results in natural cycles when adding exogenous progesterone. So in summary, regarding the luteal phase differences between these three types of cycles, we have 1 out of 3 patients with inadequate levels of progesterone, both in the pure natural cycle and in the artificial cycle. So we should measure serum progesterone in these two scenarios in order to start with the rescue treatment. Well, the second part is very quick. It's talking about the cost, and it's quick because there is only one single study comparing the cost related to the endometrial preparation with the natural cycle or artificial cycle. This is the same study I mentioned before, the Antarctica trial, and they observed that the final costs were similar in both cycles, and the cost effectiveness per baby born were also comparable. So this is not going to make us decide one or another protocol. And finally, what about the obstetrical and neonatal risk? This is a very important point nowadays, since the publication of this paper in the journal Hypertension in 2019, which showed that the risk of preeclampsia was significantly higher in artificial cycles. And this was attributed to the lack of corpus luteum in the artificial cycles. Because the corpus luteum is not only progesterone, the corpus luteum produces other vasoactive compounds that help into the maternal cardiovascular adaptation and placentation. After this publication, 2 meta-analyses and systematic reviews were published. The first one was published by Busnelli in 2022, and he observed a higher risk of preeclampsia, hypertension during pregnancy, postpartum hemorrhage in artificial cycles versus natural cycles. But he said that we should be cautious because this meta-analysis was based on retrospective studies. So clinical recommendations should not be done. The year after, SAD published another meta-analysis in Human Reproduction Update, and he also observed that in the natural cycles, there are less risk of hypertension, preeclampsia, acknowledged the limitations because included only observational studies, but he suggested that we should move to the use of natural cycle. And because of this, Busnelli answered to this paper, writing a letter to the editor and saying, be cautious with your message because perhaps the abandon of the artificial cycle could have negative consequences related to organization of the clinic or high volume of work in certain days of the week. So he suggested that we should wait for well-designed studies to conclude something. But he proposed something really interesting for me because he said that perhaps we should stratify the obstetrical risk of each individual patient according to the different risk factors taking into consideration body mass index, hypertension, adenomyosis, endometriosis, or maternal age. And if there are 2 or more factors, we should not perform an artificial cycle if we can do a natural cycle. But once again, what about the randomized control trials comparing obstetrical risk of natural versus artificial? There were 3 randomized control trials ongoing in clinicaltrial.gov, but only one has been published so far, and it has been published this year in the journal Placenta. It is a study conducted by EB Group and tried to answer the question if the risk of preeclampsia is higher in the artificial cycle. And here you can see the most important graph of this study. As you can see, the preeclampsia was not statistically significant, the prevalence of preeclampsia, but this was because of the low number of cases, only 11 cases in the total sample. So as you can see, there were 7 cases in the artificial cycle and 4 cases in the natural cycle. This is in percentage is double, but obviously we cannot make conclusions because of the low number of cases. Another interesting finding is that the early pregnancy bleeding was significantly higher in the artificial cycle. And I think that all of you have suffered this. I mean, when doing artificial cycles, we see that the patients tend to have more risk of bleeding during the first trimester. And here, the percentage of patients showing bleeding was 43%. And it is curious because another study found a similar percentage of risk of bleeding during the first trimester of pregnancy, the group of Humaydan. And they observed that in 45% of the cases of artificial cycle, patients had bleeding once they were pregnant. And curiously, those patients having bleeding showed a lower progesterone level the day of embryo transfer. At the end, this is not affecting the clinical outcome. So perhaps this means that the artificial cycle can affect on the initial placentation, and this can, at the end, or might affect on the risk of preeclampsia or other obstetrical factors. But in terms of implantation and ongoing pregnancy, we didn't see any difference either in this study or in the previous one. So just to finish, we'll have to remember the important role of the corpus luteum in embryo transfer cycles. One, because it produces vasoactive compounds which help into the maternal cardiovascular adaptation and decreases the risk of preeclampsia. And secondly, because the production of endogenous progesterone at the end decreases the amount of exogenous progesterone needed. So obviously, if we decide to use an artificial cycle, we can measure certain progesterone levels. And we know that by doing a rescue treatment, we are going to normalize the results. But why to use so much medication if we can do a modified natural cycle which avoids the needing of so much progesterone and medication? So just to conclude, I will review all these 3 points that I mentioned at the beginning of the lecture regarding the efficacy. If we are based on the randomized control trials comparing or designed to compare pregnancy outcome in these 2 types of protocol, no differences have been observed. But however, some recent analysis suggest that there can be better results in natural cycles. Regarding the cost, no differences have been seen. And finally, regarding the safety, natural cycles seem to be safer because they decrease the obstetrical risk. In any case, we need more research to confirm this, because the fact that most of the studies have been observational or retrospective increase the risk of bias or the selection bias in the population. And finally, which is the future? Well, I think that we should individualize the treatment according to the needing of each patient, because not all patients can do the same protocol. And if it is possible, we should switch to natural cycle because of these different reasons: safety, management of luteal phase support, and less medication at the end. Thank you so much.
Thank you very much for this nice presentation. I have a question if you want, please. Please, I'm here.
Here.
I do just start.
Yes.
Okay.
When the progesterone is less than 10 nanogram per, how do you do the rescue?
You mean in artificial
Yes.
cycles?
Yes.
Well, we started with subcutaneous progesterone, 1 injection per day, because my hypothesis was that perhaps there was a limit of vaginal absorption, and I tried to add another route of progesterone. So we started with this. Another groups have tried with rectal progesterone, so and it works also. Okay, so at the end, the message is, if you want to rescue, do it with another route of progesterone administration, because the capacity of vaginal absorption is limited and is patient dependent. In fact, we are analyzing even the impact of the vaginal microbiome on the absorption of progesterone, and we have found very interesting things. So this is intrinsic to the patient. So if you increase the dose of vaginal progesterone, it doesn't work in most of the cases.
Yes. Thanks a lot for this amazing lecture.
Thank you.
I am in the same philosophy from more than 4 years. I moved to ovulatory cycle. I prefer the term ovulatory cycle. And I did quite similar lecture 2 years ago for the Italian Society. But my aim was not only to demonstrate the superiority or at least equality to the natural ovulatory cycle, modified or natural, but only to show that could give us some flexibility.
Absolutely.
Because historically we was
Yeah.
thinking that artificial is flexible and not the ovulatory ones. We can have flexibility of many days, and that give us opportunity to organize our work and the workload in our lab. And I'm happy to see that such ability of yours had endorsed this attitude.
I share your
I did
opinion.
it according to my knowledge, but you did it more scientifically.
Thank you.
My question is about, do you still making hormonal assessment before triggering ovulation in modifying natural cycle?
In natural cycles,
do you
yes.
give importance to progesterone level before triggering?
Yes.
And do you still doing progesterone assessment one day or the day of transfer?
No.
Really? I didn't know.
No,
I do not.
because, well, the paper about the measurement of serum progesterone levels is going to be published soon. It's under review right now. And once we saw that in modified natural cycles, when adding progesterone, no impact on pregnancy outcome is depending on the serum progesterone levels, we stopped measuring progesterone the day of embryo transfer. But it is important, in my opinion, to measure progesterone before trigger, because we have observed that if serum progesterone levels are higher than 1 and you trigger with HCG, you arrive late to the day of
Talk
embryo transfer.
specifically about modified natural cycle.
Yeah. I'm talking about modified natural cycle.
Okay. Because I've seen many retrospective study, Groenland, they claim that progesterone the day of triggering, LH on the day of triggering had no impact on pregnancy rate. It was just a retrospective study, but the only one I find in
Yeah,
literature.
I don't agree with that. The thing is that now it's wonderful because there are novel approaches for using the natural cycles that give us a lot of flexibility.
Absolutely.
And by measuring serum progesterone levels before trigger or LH, we learn a lot, because we know if we have to advance the day of the transfer or not
Yes.
doing systematically the transfer 1 week after the trigger. Because
I agree with that.
if progesterone started to increase, we should do the embryo transfer a little bit earlier.
Totally agree.
Thank you.
Any other question? The last one, please.
The last and the quick one,
Yes.
only to have your opinion about what we read in the literature about when we manage the natural cycle and we give HCG. It was published and demonstrated that the progesterone is very high earlier and quick. So the endometrium is under the effect of progesterone more than natural cycle. So the results are lower, and a lot of the Belgium school and some others authors think that the best is the natural, but it's a little bit difficult. The manage is the worst, and the discussion is between HRT and the natural cycle. What is your opinion?
Yeah. No, the thing is that if you look to the last randomized trial in Lancet comparing pure natural and modified natural, the results are the same. Another study which has compared ACG versus no ACG found similar results.
But
I think that perhaps it's because when we give ACG, perhaps we are doing things wrongly. Okay, because we give ACG and we systematically schedule the transfer 1 week later. And I think that it has to be more individualized according to the hormonal levels. And I don't think that is affecting negatively to the pregnancy outcome, because it has been published that perhaps HCG can have a luteotrophic effect.
Yes,
This
of
has
course.
been also published. So I don't think it is detrimental.
Thank you.